So the first thing I'd like to review really is start with a couple of questions, premises. So one of the things that I would like to ask really is, do we believe we have done everything we can in terms of taking care of patients with ARDS and respiratory failure, occult lung injury? Certainly we have years now of using protective strategies, and I'm assuming in your practice everyone uses generally low tidal volume strategy. Is that fair to say? Okay. I have to say I think most people would agree, and of course there's literature to support that to some extent. But if you look carefully at mortality, and this is ARDS mortality over from 1981 to 2004. This is observational studies and randomized trials. Of course, statistically, we're not going to mix them together, so their statistical analysis is separated. That's why there's two lines here. But you can see the mortality has definitely improved since the early 80s. And it sort of hit that level around the mid-90s, early 90s. But if you look carefully, you'll see that that's really the first definition that had some consensus. Before 1992, if you look at the studies that were done, there was really a spectrum of definitions of ARDS. And it was quite clear that there was different types of patients in different groups, and the severity and how much PEEP you used, no PEEP. So you would see a lot of different definitions of ARDS. So after that, if you look from 92, after the American European Consensus Conference definition, the mortality really has not changed terribly much. And of course, remember that the observational data, we always say controlled randomized studies are the best studies, which is somewhat true, but it's not that they're perfect either. And I think what we have to also remember is sometimes they underestimate real-world mortality. In other words, a lot of the studies exclude patients. The ARDS trial excluded 70% of the patients screened. The high-frequency study is 80%. So you have to remember that in studies you sort of pick the patient to some extent, but in the real world we don't say, no, you should go home. You're not exactly the type of patient we want. You have to take care of all the patients. So observational studies tend to give you perhaps a little more of the real world mortality. Now the box here is the ARDS trial. We really enrolled patients in 1996. I'm speaking, of course, of the first one that was published in 2000, and actually completed in 1999 and the publication in 2000. And if you look again, after the ARDS trial, mortality hasn't changed much. Now, I recognize this just goes to 2004, but if we look at more recent trials, and again, this is the ARDS trial here. This is, again, established ARDS, so most of the patients are reaching a blood gas criteria for ARDS to become enrolled in these studies. So if you look carefully, this is the LOVE trial, EXPRESS, the ALIEN, the OSCAR, OSCILLATE. Now these are high-frequency studies, but the control arm is low tidal volume. So this is the mortality in the low tidal volume, not the HFOV arm. And you can see again, it doesn't seem like we've had tremendous impact. I mean, the mortality is still, in my view, unacceptable. I think this is still too high, and can we do better? Or at least should we try to do better? Because it's not been easy. It certainly isn't been because of money. We were talking about at lunch today. ARDSNet cost $41 million US, and certainly billions of dollars have been spent on research spanning many, many years, and we've come up with very few things that actually have shown to be of any benefit. This is just a paper, a current opinion, but some opinion leaders also believe that despite lung protection, which really comes down to my next question, which is what is lung protection? Is it really just reducing the tidal volume, or is there a lot more to it? And do we understand enough to actually be making complete recommendations? And I think it's important that we don't limit ourselves to just this one concept of tidal volume. Sorry, I didn't mean to show you this. Not sure where this is here. Okay, apologize. So I did, you might remember this paper. Of course, I was showing you the hemodynamics in this paper, but more importantly, what I would like to show in this paper is the idea of stress strain. And perhaps this is a better way to describe lung injury, is from the mechanical perspective of applying a stress and determining the strain that occurs in the tissue, and of course, deforming an organ like the lung. As long as you deform it and it returns back to its normal shape, you're generally okay. Like if you take a rubber band and you do this and you let it come back. But if you distort it to the point where it cannot return to its normal shape, well then you may have problems. And so the question here, again, comes back to refining our understanding of what's happening in the lung and what we're doing with the ventilator when we choose to set it in certain fashions. So I think at least this is trying to answer a simple question, is if you have the total strain, so the load on the lung is the same, and again in this case it's 2.5 times FRC, so you're very close to total lung capacity. But if you create this big strain in the lung by deforming the lung tremendously from no PEEP to big tidal volume, or if you keep the lung in a progressively more static inflation, and you can already tell from this morning that what we're doing with EPRV is relatively static. So it's very minimal movement. We're trying not to move the lung in a dynamic fashion. Now certainly you can look at the ventilator and say the pressure is 30 going to 0. It sure looks very dynamic. But in the lung, it's actually not so dynamic, and I'll show you that. But clearly, even though it's the same total strain, the lungs look completely different after 53 hours of ventilation. This being static versus dynamic. So total strain is the same, but the nature of how the strain is important. And again, I'll tell you another quick story about Luciano Gattinoni, because I think he's really a very smart man that's actually helped me for many years understand things. So we were at a meeting in Pittsburgh, and this article was not published, and he was telling me about it and discussing it with our research group. And what he did was he took his hand and he punched my face, and he said, static is like hitting you in the face and holding my hand here, versus dynamic, I would keep going back and forth and back and forth and back. That was just his, again, colorful way of illustrating static versus dynamic. So perhaps we shouldn't be punching the lung, and just punch it once and hold it and keep it relatively stable. So now I think it's important to discuss, what do we really know about the mechanistic understanding of what we do with low tidal volume, how we protect it, and so on. And I think this is really important because science is really about clarity. The clearer we are in our concepts, the clearer we are in our understanding, the more likely we are to define a problem accurately, and then the solution is more accurate. So for us, I think it's really important. And one thing that I've struggled with is that because evidence-based medicine, actually, if you read the original proposal of evidence-based medicine, it is not that you should just accept evidence, period. It is, we want to look at evidence-based, but it has to make mechanistic, we have to have a mechanistic understanding. So there can't be, it works, but there's a big question mark, it's because of magic, it's because of this or that. There has to be an explanation. And one thing that's clear is that there isn't really a clear explanation for why low tidal volume works. In fact, the ARDS published a paper trying to figure out why it worked. The 2000 paper worked. And they ultimately concluded it was biotrauma, because there certainly wasn't any difference in barotrauma. In fact, I'll tell you, in all of these studies, there's no difference in barotrauma. Whether it's HFOV, whether it's high PEEP, low PEEP, there's no difference in barotrauma at all. So the conclusion is biotrauma. But I think one of the things is, if you look at the papers that talk about the mechanism, they always say we're preventing or limiting. What are we limiting? What would you say we're limiting by reducing the tidal volume? Yes, but how? Over distension? Is that fair to say that we're limiting stretch injury over distension? Well, that's certainly what most of the papers say, is that we're avoiding, by using 6 mLs versus 12 mLs, we're avoiding stretch or overdistension. But honestly, we have looked high and low, and I cannot find any mechanistic evidence that that actually exists. And there's several papers now that is really suggesting that there's really no overdistension at all. It's really R&D, or recruitment, derecruitment, is the primary mechanism of ventilator-induced lung injury, not overdistension. And in fact, if you go back 20 years, you'll find that the great physiologists actually commented on the alveoli do not overdistend. Geometrically, may be impossible, because it's not a balloon, it's like a honeycomb. And if you pressurize one versus the other, the pressure is pushed against each other, and they stay relatively stable. In fact, what they describe is that the alveoli get smaller as you use more pressure. And so this is a study we did looking at with alveolar microscopy, and this is continuous positive air pressure up to 50, normal lung here in blue, and injured lung here in yellow or gold. And you can see that at some point the lung actually gets smaller, the alveoli. We're looking at the alveolar size, dimension, using high definition microscopy. So we have not been able to find any evidence that overdistension occurs. Now, again, I'm not saying that we should not consider overdistension, or this is not an important problem, or it's really, again, clarifying where it is. And I will tell you what we have found is what really gets big is the duct. And in fact, this is what was described in the past, is the alveolar duct gets big. And as the alveolar duct gets big, the actual alveoli get flat into the duct. So if you can just envision the ventilator tubing, the corrugated tubing, if you were to blow up the tube, the corrugations would ultimately just disappear into the tubing. They'd become very flat and go into the tubing. And what we find is the duct is that gets really quite big. And the duct has, depending on what you use, if you use PEEP, the duct gets big and the alveoli stay the same size. If you use APRV, the alveoli get bigger, but the duct does not. And so it becomes an important distinction between the two. Now, here is one of our studies where we're looking at low tidal volume. And I think just fundamentally, I would just have to say that when you think about low tidal volume, I think it also makes some assumptions. It assumes that we really have balloon-like inflation of the lung. And if you think about a balloon, if you put less air and pressure in it, the strain in the wall of the balloon will go down. But is that the case in the lung? Because if it's not the case, then it's hard for us to use the balloon analogy so strongly. And what we realize is you have to understand not just the stress, which is the pressure and the volume, but where is that stress going? You know, I'll just use a hemodynamic analogy quickly. Does it really matter what your cardiac output is, or where is your cardiac output going? I mean, we certainly have seen people with high cardiac outputs have very bad perfusion, fingers falling off, in horrible shock, distributive shock, because the cardiac output's not perfusing everything. So perhaps a more complete thought would be not understanding just the stress, but understanding the strain and the distribution of that strain, because ultimately the destruction of the tissue is going to be how well that organ can accommodate the stress. And if the stress is distributed over a large area, the strain is going to be manageable. And of course, this is what your normal lung does, huge surface area that can dissipate a lot of energy. So that's why I want to say the ventilator here is going to continue to say, you know, maybe instead of flashing 6 mLs per kg, it should just say lung protective, lung protective, lung protective. But is it really lung protective in the lung? We don't really care about what the ventilator says. We care more about what the lung is happening. Now, these lungs that I'm showing you were injured by deactivating surfactant. So we're making the lung unstable. And then this is APRV. So the APRV lung looks a little bit healthier. It's not quite as swollen. Of course, it's better inflated. And you can see this is releasing to 0. Of course, there's no chest wall here, which also would have a contribution to where the lung is moving. But here is zero pressure. And I'm just curious to know, the first slide I showed you with this is 6 mLs per kg. What I'd like to know is what you think the tidal volumes are right here. Is it more than 6 or less than 6? Is it 4? Is it 2? Is it 12? Is it 10? What would you guess the tidal volume is, mLs per kg?
15.
Anybody?
7?
7? Okay, we have 7. Anyone else? Going once, going twice? Okay, this is 12 mLs per kg. So this is a 12 ml per kg tidal volume. And the lung's not moving very much, but you can see the distribution is really quite different. And perhaps the stress-strain relationships are going to be different. And perhaps the potential for lung injury is going to be different. So twice as much tidal volume. The lung is barely moving. Again, we're going to 0, but we're controlling the lung on both the inspiratory, expiratory phase with time, which is perhaps a very important contribution to what's going on. I'm not sure what happened to my talk. I apologize. This somehow got out of order. And so I think that time may be really important. And we wrote this editorial because if you really come down to it again, and I like to say the fact that acronyms, if we rely on acronyms to describe what we're doing to the lung, we're making a big mistake. If you say SIMV, well, you can make SIMV look multiple different ways. If you use APRV, you can make APRV look like pressure control. It can look like almost CPAP. You could do a multitude of things. Now, the lung doesn't understand the names. The lung understands what we would call the mechanical breath profile. I don't know if that's a good term. We made that up just because what we're trying to describe is the fingerprint of the breath. How does the breath affect the lung in its inflation, its deflation, the time course of those things? And you have a picture of it right here. Now, for whatever reason, people have focused on plateau pressure, tidal volume, and PEEP. And my only question is that it? Or are there other elements of the breath profile that affect the mechanical behavior of the lung and can actually be adjusted to either help us or hurt us anyway? But are those the only parameters? So far, we've identified 10 components of the breath. And we already sort of know, at least in a controlled randomized fashion, that if you just manipulate plateau pressure and tidal volume, that you may affect the way outcome is. So just affecting those 2 parameters, so why not adjust 3 or 4 or 5 in different directions and see what's going on? So I believe time is important. You've seen this, so we won't belabor this, but I'll just summarize again that there's a time dependency of the lung. In fact, lung inflation, deflation is really dictated by time constants, not pressure constants, time constants. And time constants, of course, have a lot to do with resistance and elastance, resistance and compliance. Either way, you're really talking about more of the mechanical behavior of the lung and its time course for inflation. Now, of course, you can leave the lung in static inflation, which is CPAP. We could do that, and if the patient's not breathing, you're going to have a problem leaving them in CPAP. Or if the patient is breathing, but they're have a big metabolic load, if they're septic, if they're producing a lot of carbon dioxide, CPAP may not be enough support from the metabolic perspective, from the ventilatory perspective. So if someone's carbon dioxide production doubles because they're septic, they may be ventilating too much and their work of breathing is going to go up. Not because elastically there's a problem, just because metabolically there's a problem. So we will have to aid in CO2 removal. So again, how do we do that? Well, what we want to do is interrupt the pressure so we can remove some carbon dioxide, because we have to at some point convect carbon dioxide. Even if we diffuse, at some point it has to physically leave the body. So we must always have a convective piece. So the convective piece in APRV is that brief release, and the whole idea is to release it without changing the lung. So if you can keep the lung still and ventilate, then perhaps we're using less dynamic energy in the ventilator. And of course you can see here, again, just that little twitch is a big tidal volume for a very brief moment. And the lung doesn't really change its size too much. And I'll show you a couple other studies, but there's less than 10% change in alveolar volume between inspiration and expiration, even though the tidal volume is quite large, even though it looks as though we're going from 30 to 0 or 20 to 0 or some kind of number where you look at the ventilator and you say to yourself, this has to be injuring the lungs, not protecting the lungs. And especially if you just focus on tidal volumes. So our concept, which actually was just published in, I think, a month ago in Chest. I bring this up because this is I would just tell you, this is a review of all of the papers we have to date, multiple. It's well referenced with all of our data. And the idea here for us is that we've heard many, many years now that the ventilator can destroy and hurt the lung, ventilator-induced lung injury. I think perhaps the bulk of the work that's been done in the modern era is really focused on that. Not all of it's perfect, but there's no doubt in my mind that the ventilator can be a very, very dangerous part of ICU care. There's no question in my mind. But could you have the opposite true? Or is that just too insane to think that, wait a minute, the ventilator set in another way could actually do just the opposite of injuring the lung? It actually could be therapeutic. You know, we always use ventilators to support the patient until they get better, but could it be therapeutic that somehow we can prevent the lung from actually developing a common type of lung injury that affects many of our patients? So at this point, I just want to go over some of the data because we won't have time to do all of the data. I'll start with just the clinical paper. And this is really just looking at the trauma phenotype. And we were talking about this at dinner. Ula and I were discussing that, you know, one of the problems I think we have is that we're talking about syndromes. We're not talking about real diseases which have distinct biologic signatures. A syndrome is a collection of signs and symptoms, and you have the same as I do, so we put you in the same bucket, but there may be some subtle differences between me and you. You know, I'm a trauma patient, you're a medical patient. There's a lot of perhaps differences that affect things like the chest wall and the abdomen, and those things might have an effect on how you respond to mechanical ventilation. And yet we haven't really taken enough time to sort of try to understand it. So we attempted at least to say, at least they're all trauma patients. And trauma patients trauma and surgical patients are really underrepresented in all of the studies. If you take all of the modern studies, more than 7,000 patients, 3.5% of those patients were trauma or surgical. The rest were medical patients. So it's a very small representation. So if you deal with trauma patients or post-surgical patients, it may not be clear that absolutely the same approach in the medical patient is important here. And we know that there is a difference in their chest wall mechanics, which might be really important. So these are our patients, 231 patients, and these are our trauma patients. And you know, for years we started using this as rescue, and then we went to early, and next thing you know, we're using it as soon as the patient's intubated, and my ECMO program disappeared, and proning disappeared, almost. I mean, obviously we still use ECMO occasionally, or not for our patients, but for transfers, proning very little. And we had a very low ARDS rate from a very high ARDS rate. So we, of course, wanted to understand why. So we looked a little bit at this, and we decided to take our patients that are at risk, because now we're using it early. We're not waiting for them to have established ARDS. As soon as you require mechanical ventilation, we put you on EPRV. So these 231 patients were put on EPRV as soon as they were intubated, or very close to that time. And we're going to compare this to other trauma patients, total of 66,000 trauma patients that we're going to compare them to, with very similar injuries. And here's just an idea of our patients. Injury severity score 29, at least one femur fracture, more than 20-25% had two, chest injury, abdominal injury, brain injury. These are the scores. All of this is associated with acute lung injury in the trauma population. So if you read the trauma literature, you'll find that these things are, actually in ISS more than 17 is associated with it. And so you'll frequently find this, because our goal was to look at high-risk patients. Because remember, they don't have ARDS. These are patients with, the idea is to prevent it from happening. And here's resuscitation. And as I said, this is really a very close link to lung injury. And I'll just go over some combat data. In Korea, there was the Korean conflict. The soldiers, the US soldiers, died of renal failure. Or renal failure was a major complication. And right after Korea to Vietnam, there was a lot of work on shock resuscitation. And so in Vietnam was the first US involved war where they resuscitated the patients, the soldiers in the field, and they didn't have renal failure. They ended up having lung failure, ARDS, Da Nang lung. So there was a big bump in lung injury and ARDS after fluid resuscitation. So there seems to be an important relationship between shock, the need for resuscitating a patient, permeability, and driving more water into the lung. And remember, lung edema is a very proximal event in unhinging the lung's ability to keep itself stable. Because once you get a little edema, surfactant becomes deactive. As soon as you deactivate surfactant, the lung is popping open, close all the time. And actually very hard to stabilize. So the resuscitation, this is the first 24 hours. 10.6 units of blood, 8.6 units of FFP, and 11.5 liters of crystalloid. So they received a lot of blood products and fluid. Again, the first 24 hours. Some people ask me, is that over the 5 days? I said, no, it's the first 24 hours. The other thing we did was, again, we're trying to make sure we're looking at a high-risk group of patients. So we decided to use this. If you're not familiar with this is called the Lung Injury Prediction Scale. And again, it's really just a lot of data from many centers and looking at which ones statistically have the most predictive value, and then putting them together on a sheet of paper like this. And basically, you can do this as soon as your patient comes to your hospital, and you can give them some points, and the more points they have, the more likely they are to have lung injury. And it looks like this. If you read this paper carefully, you'll find that the positive predictive value isn't as good as the negative predictive value. The negative predictive value is very high. Again, not necessarily saying that if you have this score, you're going to get this percent of patients having ARDS, but if you have a score that's high, you are studying a very at-risk group of patients. And so our patients, the mean score was 8.7, and so you can see that hopefully we were looking at a group of sick patients, because it's harder to answer the question, I think, that we prevented something from happening. Was it going to happen or not happen? I don't know. So at the very least, we wanted to do our best to make sure the patients were really very severely traumatized, required a lot of resuscitation, and at least by score had a high predictive score for lung injury. So here's the results. Our patients are in these yellow blocks. So the mean ISS is 29.7, which is in the upper quartile. The mean for the 66 other thousand patients was 25. So let's just call it the same number. But our patients were not less injured. They were just as injured, perhaps a little bit more. Our ARDS rate was incidence was 1.3 versus 14%, and the mortality is 3.6 versus 14%. We actually had 0 ARDS mortality. This is in-hospital mortality. And probably the number one cause was brain injury. So this is, actually a big difference. Now, this is not a controlled randomized trial. I'm not going to tell you this proves that this works. But after that, we decided to go to the lab. Because again, I think one of the problems we have in the ICU is clinical medicine. Clinical studies are really very, very difficult. We have a spectrum of patients that we don't really define. If they have the same symptom cluster, we say you're the same as this person. We don't deal with diseases. We deal with a lot of interventions. Our cardiology colleagues, it's much easier. They can look at an EKG, an echo. They can check biomarkers in the blood and determine what's going on with the patient precisely. And then they can take 10,000 patients and give them a placebo and another 10,000 and give them drug A and see if drug A works better than placebo. and they have to just take the pill. We have to use a lot of interventions. We have to adjust the ventilator. We have to make sure the ventilator is adjusted. We have to make sure the antibiotics are correct. We have to make sure that the hemoglobin's okay, and we don't give too much blood products, and we don't give too much fluid. We have to do a bunch of confounding variables that make it very difficult for us to really, in my view, get science out of the ICU. So the lab sometimes is helpful. And so what we did is, and these are actually several papers that we published, but I just really want to focus on one. Our lab is essentially an ICU. We have all of the animals have Swan-Ganz catheters. They're on ICU grade ventilation. We do everything as you would in the ICU. Our management is all ICU. The model we have is sepsis and ischemia reperfusion. And we wanted essentially to ask the question, if we take a pig with normal lungs and we give it a horrible uncontrolled septic shock with gut ischemia, will we be able to prevent the animal from having ARDS? Experiment is 48 hours long, which is really important because human diseases don't manifest in a 6-hour ventilator-induced lung injury trial, I can promise you. Two hits, all ICU standards. We do this model because it's 100% ARDS rate. At 48 hours, we have blood gas, histology, inflammatory markers, gross appearance, all markers that we've essentially destroyed the lung. And so in order to prevent it, we have to make sure we can produce it. So these animals are really, really quite sick in an extreme fashion. And you can see they're hyperlipemic. We don't do anything with their sepsis except put stool in their abdomen and close their abdomen. And they're on norepinephrine, vasopressin, surviving sepsis guidelines. And of course, they receive a tremendous amount of fluid. The pigs are 34 kilograms. So if you look at the weight of this fluid, 57 liters of fluid, that's more than the pig weighs. So the pile of fluid is much. So this is obviously very extreme, and as you can imagine, there's a reason why we have 100% ARDS rate with this model. The pigs look like this, and then they look like this midway, and then they're very, very tight as a drum, horrible shock. I have a picture of my hand on the side of the pig. Half hour later, my hand is still there. How bad their capillary blood flow is. I have to bring that picture out. So here's the study. Here's the groups. We have APRV, as Penny described, the P high, the P low, the expiratory flow here. So we're very careful about our methodology. We always use the same methodology. The tidal volumes, we weren't targeting tidal volume, but this is what we got. If you set the release this way, you're going to get what the lung, I believe, wants to give you, and it just so happened to be in this range. The sham group is on 5 of PEEP, 10 mLs per kg tidal volume, and we have an incision, and then we close the incision. There's no sepsis, there's no SMA clamping or gut ischemia, they're not on norepinephrine, and they certainly don't receive 57 liters of fluid. So that, to some extent, is our control group. And of course, you see the low tidal volume strategy. Here is the PF ratio. You can see the PF ratio. The APRV animals are on 21% the whole time. The low tidal volume animals at hour 30 develop blood gas criteria for ARDS. We talked about this last night. This is compliance. You see the compliance is very high in APRV, which used to drive me crazy, but because I just couldn't explain this. But you can see that at least it's preserved, and in low tidal volume, the compliance goes down. So after 48 hours of that horrible shock, this is what the lungs look like grossly when you take them out. You can see these are obviously very injured lungs. This is 25 centimeters of inflation. We always inflate the lungs as we take them out because we want to standardize the histology. If you let the lung collapse, the histology will look terrible. It will all look the same. So we do everything in the standard fashion. This is what the APRV lungs look like after 48 hours of the same shock. 25 centimeters, you can see their total lung capacity. Of course, we don't have the chest wall stopping anything. So dramatically different, relatively pink, healthy. I'll just show you quickly a few other animals. This is flipped over. This is the cardiac lobe here. This is where the heart would be. These are all low tidal volume. You can see how much this very thickened fluid between the intralobular septa. They get very, very wide, and of course a lot of congestion and hemorrhage. And I'll just show you some APRV animals very quickly. Histology, you can see the histology here. Single cells, very clear alveoli. This is classic diffuse alveolar damage. Even the sham group, their histology looks worse than the very sick APRV animals. I apologize for running through this very quickly, but low tidal volume, this is the BAL, IL-6 very high, as TNF-alpha, IL-8, sham and APRV very low inflammation. Systemically, the inflammatory markers are sky high in the APRV and the low tidal volume group. They're systemically septic. But when you look at lung inflammation with a BAL, you see that there's very little inflammation in the lung. Surfactant, and I'll run through this very, very quickly. We have typically a signal with surfactant A and B, showing that it's better preserved. Epithelial layer of the lung. Remember, the lung is really a big, it's like your skin. It's all epithelial layer except for a type 2 cell every now and then. It's a barrier layer, and so we wanted to see how well the barrier or the epithelialization is preserved on the alveolar surface, and you can see a difference there, statistically significant. But, you know, again, because I just don't have that much time, I just want to essentially try to press upon you that if we stay stuck on the ventilator, it would be analogous, in my view, to looking at shock patients and just saying, once you get a stable blood pressure, that's all you have to do, and not looking at lactate, perfusion, microcirculation. And so I think with the ventilator, we're stuck in this particular area, and that we need to think beyond this to understand what's really happening in the lung. You know, the APRV, again, would look, if you stopped at the ventilator, as this must be incredibly injurious. They're not using any PEEP. They're using 12, 15 mLs per kg tidal volume. They have to be destroying the lung. Well, you can see the lung is not destroyed. And this is just one study. I can show you multiple studies, same exact results, same biomarkers, same histology, rat models, pig models, same thing. We see the exact same thing. And one of the key things is just really, in my view, understanding the micro environment. Perhaps I can just go over this one last study with you, which is trying to figure out why is there such a discordance between what you see on the ventilator and what you see in the lung. And you'll have to bear with me here, but we're going to try to describe the tidal volume at the alveolar level. So the difference between inspiration, expiration, if you look at an individual alveolus. Similar to when you look at the whole lung, inspiration, expiration, we call that a tidal volume. So the alveolar tidal volume is the change between the two. And here we create lung instability. Here's inspiration, expiration. We use PEEP. We use what we call poorly set APRV, PEEP of 16. And this is properly set APRV. And you can see between inspiration and expiration is very little change. And actually the delta change in tidal volume is very, very small. You can see with PEEP, the same thing happens. The delta volume with R5 of PEEP does not really do too much. There's still a lot of change in tidal volume. So alveolar tidal volume is actually big here. It's small when the PEEP goes up or an APRV. The difference between higher PEEP and APRV is that APRV generally recruits better. So this is the number of alveoli that you show up in a particular area. So you can see that there's a little more recruitment. And when we look at the alveolar tidal volume, you can see when you set the TLO incorrectly, it's really high. Alveolar tidal volume is high, which is over here. And as you set the TLO correctly, you'll find that the alveolar tidal volume actually becomes very, very low. It's actually lower than low tidal volume, even though the whole lung tidal volume is 11 mLs per kg on this slide. So we have 11 mLs per kg, but the change in alveolar volume is very, very little. So if you want to know low tidal volume at the alveolar side, then APRV is actually a very low alveolar volume tidal volume strategy, actually lower than low tidal volume. I think I can end there.
It's very interesting,
I think I can end there, yes.
but not very peculiar.
Sorry for the quick version.
Still from all the other question maybe?
Sir?
How did their lungs look like in the sham group? Were
They had basilar collapse. And I think the problem is, we didn't change the PEEP. Even though they were not really sick, we just left them in supine position. Pigs don't like being supine, just like our patients don't like being supine. So I think at some point they get basilar collapse, and I think that's the problem. And there is evidence to suggest that when you take healthy lungs and you just ventilate them with standard ventilation, you will ultimately develop some degree of lung injury. So even in what we call benign settings, it seems to be not natural and potentially changes the distribution of ventilation and so on. That's why I think your patient breathing would be the most protected if they could breathe comfortably. Other questions? Thank you so much.